Hello, nurse. This is Kevin with nursingkamp.com, and I'm going to talk to you about pancreatitis. All right, nursing AR. Nurse walks into the room. Pancreatitis. What does the patient look like? Well, the patient would be side lying or in the fetal position, be complaining of pain, and this is an acute situation. Assessment plays a big part, as well as implementation, so let's go into it. Pain is key. Now, the big thing about pain is location of the pancreas in relationship to the liver and the gallbladder. So you have the gallbladder that's behind the liver, and then it connects to the common bile duct, and it goes down into the pancreas, and then where it gets secreted into the duodenum. So endocrine and exocrine all good. Okay, pain. The big thing is that it's going to be mid-epigastric pain, right about here. And it's also going to be going to the left shoulder. And these are characteristic signs of pancreatitis. And they'll be guarding, and it'll be tender. And that's an interesting part because on the left side, the pancreas is more over here, so it kicks over to the left side. And that's when we talk about the gallbladder here. The gallbladder is actually located behind the liver, and it causes a right shoulder pain and the back shoulder here. So if you have a fatty hamburger and everything like that, you get that right shoulder pain. That's your gallbladder talking to you. All right. The big thing about diagnostic procedures and to look at then the liver and the gallbladder, you never ever give contrast first. Because in order to isolate the gallbladder here, if you gave contrast, you would wash out and you wouldn't be able to see the gallbladder. So the gallbladder is always looked at first, and then contrast may be given. All right. So we talked about how the GI tract goes to the stomach, and the stomach has hydrochloric acid in it, and then it comes out, and this is where the pancreas actually starts to secrete. And the big thing about this is the gallbladder is over here, and there's a bifurcation of a left hepatic and right hepatic duct. And when you come down here, this is the common bile duct here. And sometimes people don't have this bifurcation over here. And the actual, no, not this bifurcation, this bifurcation over here. So it's the common bile duct actually goes into one. The other thing is that hydrochloric acid is neutralized by the pancreas in the form of bicarb. But also the pancreas also secretes other digestive enzymes to break down fats. That's a big key because those fats are ADK, a fat-soluble vitamins, so they tend to be deficient in this ADK. And that's people with chronic pancreatitis tend to have fatty stools. Another common thing too is that when we're looking at our bowel sounds, we always listen in the lower right quadrant because that's where the cecum enters from the large intestine, from the small intestine into the large intestine, and then we go this way. Because if you're going to hear it anywhere, it's going to be right here, your bowel sounds. So always start here first. Another thing too, why we'd be monitoring bowel sounds is because of patients with pancreatitis get paralytic ileus. And that's an acute situation. All right, moving on. All right, so let's do our liver diagram. So this is the Superman diagram. And like I said, these are diagrams that I made up mainly to teach. But you probably have seen this one before. Sometimes it's this, which kind of looks like a BMP, but there's other enzyme, liver in this. But I generally will always do this. If it's pancreatitis, I add that. If it's end stage liver disease, I add this, and I'll explain that in a second. Okay, so this looks like a 10. So we put 10. 10 there. There are 4 spaces, 1, 2, 3, 4. So that gets me to my 1040. Okay, once I have 40, then I have 1050. And then what I do is I add this 10 and then this 10, and I get 20. Then I put 20 there, and I put 20 there. So I have 40, 50, and then I go 160, 160, 160, and that gives me that. Then I have my albumin up here, which is 3, 4, 5, 6, point, and that's your albumin. Over here, you have your ammonia. That's this, 45, 0 to 45. And then over here is your bilirubin. And your bilirubin, again, 4 spaces. 1, 2, 0.4. Okay. All right, so that's it for the numbers. So let's look at the talk a little bit about the actual lab values. All right. Okay, so AST. Always start start with there, and then ALT over here. acid, it's systemic and liver. So this could be elevated on a systemic infection. However, it is a liver enzyme. It's mainly the response of the liver. And then this one is specific to liver, L, liver. Okay, those are your main liver enzymes. And your alkaline phosphatase is a byproduct. And then you have amylase over here. Always start with A, amylase. I think ACE is high, right? And then lipase. Okay, these are elevated. Now, NCLEX will always just give you these. They basically will go, this goes first. A always goes first. And this one's basically raises for 12 hours. And then this one's last, follows afterwards. So you have your amylase raise and then your lipase second. And lipase can actually be up to, I think, 2 weeks. Albumin over here. Albumin is the true functioning of the liver. Okay, because albumin stays in the body for 45 days. So if you have a low albumin, you have a liver problem production, because albumin is made in the liver. And albumin loves water. So the whole principle is if you have a low albumin, you have a problem third spacing. That's why you see ascites on a liver patient. It is because of the no albumin. And that's funny because of what we do in patients in the ICU who have really third spaced and it's swollen. We will give them albumin. And what that will do is it'll pull the fluid from the outside into the vasculature, therefore taking this edema and to go. All right, just something to know. All right, that's your liver enzymes. Now in the hospital, you know, as soon as you'll see SGOT, SGPT, same thing. The thing about that is that these are These numbers right here, they generally will start to rise in early stages of cirrhosis. But eventually, like anything with cirrhosis, the cirrhosis is scarred tissue. Okay? So when you have an injury of a liver, it starts to build, it starts to repair it, but eventually this becomes like a scar tissue. And when you first start, kind of think of it like flames. When the liver's getting damaged, the AST and ALT start to elevate, okay? But once you have flames, then you have ashes. And you can still see smoke, but it's no longer producing any more elevated enzymes. But we're going to talk about amylase and lipase, all right, and with your pancreatitis. All right, so here's my pancreatitis. Pancreatitis is an inflammation of the pancreas, resulting from chronic alcohol use, gallbladders, or what I call the cage. Cage is cystic fibrosis, alcohol, gallstones, and ERCP. Now that's a actual scope that goes down the GI tract, and it goes all the way down through the stomach, and it hits to the pancreas, the common bile duct to the liver, and it basically goes up here and is looking at the liver, and well, the gallbladder. And it's looking for stones, and that's a big problem with this cage, is that sometimes gallstones will cause a backup into the pancreas. We'll look at that when we look at the anatomy. Okay. Then we have, when we go through the sheet, we have acute over here, and then we have chronic ongoing there, and then we'll go through the labs. All right, labs first. Okay, so first is your BMP. So your BMP has your sodium and potassium. They'll both be low. Mainly potassium's low because of peeing, puking, pooping. And then low sodium because of a high lipidemia. There's also a BUN and creatinine elevation, which could go into a pre-renal failure. Also, we're going to be monitoring sugars. So these patients are going to require, because think about it, the pancreas is here, and that pancreas is shut down. So therefore, the body is still utilizing glucose, but no insulin is being produced. Well, it's being produced, but it's just not getting to the bloodstream. And when it doesn't get to the bloodstream, it means that in the bloodstream, it's going to be hypoglycemic. So they're going to have signs and symptoms of hypoglycemia. All right, next thing is white count will be elevated, because as this pancreas starts to auto-digest, it starts to eat itself, basically. You start to get an inflammation, mass inflammation. And the biggest risk of that is that they actually end up getting ARDS, inflammation, and ultimately sepsis if not treated correctly. These patients are surgical candidates when we talk about it. All right, so we said that AST, ALT are elevated, amylase and lipase are elevated, and also they get hypocalcemia, low potassium, low phosphorus. And the main reason that is because these are the signs and symptoms. And the big thing about that is why are they hypocalcemic? Well, there's a lot of different theories on it. One is the PTH, parathyroid, hypocalcemia. Also, tissue, muscle damage, fat necrotizing is releasing and absorbing this calcium. But we're mainly talking about bound calcium, not unbound calcium. But the key here is to look for the signs and symptoms. See, there was once a time where, calcium, mag, phos, we had 1, 2, 3, 4, 0.5, 0.5, 0.5, 0.5. It used to be 6 to 10, And I used to write it like this, 6 with the claw, and then 10, because hypocalcemia used to give you the trousseaus, which is this, and then trevectics, which is you tap the tight side of this thing. So they have tetany-like symptoms, tetany and twitching and stuff. But then what happened was we stopped monitoring the labs at 6 because we realized that we didn't care so much that the circulatory calcium, we cared more about 8 to 5. That's when you add this 3 and 5 and you bring it up there. Now you have 8.5 to 10. This is really what's called calcium bound. Okay, to what? Proteins, albumin. And so that's the new monitoring. That's what we monitor now, is we monitor the bound protein to calciums. All right. That's about all the labs that you'd see with this patient. You'll also see LDH and stuff like that. Okay. All right, so let's talk about what is it caused by. I said that the cage is the main one, right? So cystic fibrosis, alcoholism, gallbladder disease, and ERCP procedures. This is an important procedure to recognize because patients who have gallbladders, they get an ERCP. And usually these post-op patients, post-procedures, usually show signs and symptoms of pancreatitis. And it's a big tested thing and to see what's going on. So you have gallstones here. You have alcohol abuse. Trauma can cause it, but that's not the most likely. Steroids long-term. So think cystic fibrosis, right? So inflammation, fluid shifts, and all that stuff. Mumps is actually a cause. Autoimmune disease, not the most likely. Scorpion stings is interesting. That's more for the CNE exam. CNE exam is a RN, ER certification. And then hypertriglycerides. High triglycerides and ERCP is the main one. And sometimes drugs can cause it. Once you have it, erase all things, do this. You're going to have hypoglycemia, so you have calcium go. You're going to monitor those sugars, glucose, insulin. You're going to drop an NG tube in. And the reason you drop an NG tube in, and we talked about that in class, and the reason you drop it in is that gut has to stay rested. And what you want is no fluids going in here. Because every time fluids go in here, the pancreas is going to want to work and try to secrete in the duodenum, because the job of the pancreas is to secrete bicarb into the duodenum. And all the sensors are triggered from the duodenum. So every time it feels things go in there, it's going to try to squeeze bicarb out. But if this pancreas, doctor, can't remember his name, is inflamed, and this is inflamed, it auto-digests itself. So we put an NG tube in, nothing by mouth. And we say that nothing, I mean absolutely nothing. No water, no sipping, no ACE strips, nothing. Because that will stimulate, cause for gastric emptying, which will then cause for more inflammation of that pancreas. Pain management is key for these patients. The big thing about pain management and medications is there's a lot of, if you're doing a lot of questions, you're going to see a lot of questions about morphine. Now, this is kind of all over the place, Some places you give it, some places you don't give it. They talk about the sphincter of Oddi and how it spasms that sphincter. So they say you should only give dilaudid. And then sometimes people make mistakes and they say, oh, no, it's morphine, or no, it's just dilaudid. So those questions tend to be all over the place, which means that I don't test on it. That's a non-tested item for me. And I also think for the NCLEX, they're not going to test on this because there's a lot of studies out about this. It's the same thing with hypocalcemia. They don't really know why. They have some theories on it, but it's just definitely, it is a thing that's there, but they don't really know why it is. There's a lot of evidence-based practice studies, but a lot of times people don't have it. All right, IV fluids are key, right? MPO, and then TPN. So you just have to feed this person without feeding them. Okay. Next thing is, oh, my face is in the middle of this thing, is what's acute? Okay, sorry about that. I had to move the slide around a little bit there. All right, so let's see, where are we? So we're at the point of here. So what's acute? Well, the interesting thing is that chronic pancreatitis and acute pancreatitis, chronic can always become acute. So in an acute episode, it's usually these things over here that are going on that cause this acute thing, or chronic pancreatitis. All right, so some things that you see, shop scent. The risk is shock, hypovolemic shock. The patients are going to get a lot of fluids during this time. And basically what happens is you start to see fluid shifts. And once you see fluid shifts, they actually can get hypovolemic. So you keep an eye out for that. Hypovolemic is high heart rate, low CVP, and low blood pressure. All right, cool, clammy skin. Hiccups. It sounds kind of funny, right? But in actuality, pancreatitis irritates the diaphragm because it's actually self-digesting itself, auto-digesting itself. And these pancreatic enzymes start to release, and then if you look at the position of it, it's actually right where the diaphragm is. And once it starts to get stimulated and start to affect this area, you start to get hiccups. That's what happens. Hiccup. You start to get severe abdominal pain. Respiratory distress, peritonitis is the major risk. So that's board-like abdomen that you tend to see. Chills, epigastric paint loss. That's a typo. And then nausea, vomiting. Gut, tachycardia, definitely. All right. So what do we look for? We look for Cullen's sign. Right? So there's two different things. So if you have the body here and didn't commit to that face anyway. So there's two specific things. Cullen, right, which is, I always think Cullen's chubby belly. So you get these ecchymosis around the belly button. That's called Cullen's sign. That's acute. And it's acute because it's bleeding. So that patient that has Cullen's sign is bleeding. There's also Turner trunk. So see Turner on the trunk of the chest, the sides. You turn that person around, you see these kind of bluish ecchymosis. And that bluish sign is a classic sign of retroperitoneal bleeding. Two characteristic signs that are acute means that this patient needs to go down to the OR immediately. Hypoglycemia, we're going to be monitoring for that, signs and symptoms of this. They might get on an insulin drip. They could ultimately destroy that pancreas so much that they become type 1. Ascites, again, inflammation, left shoulder pain, knee to chest position. Sometimes they want that kind of knee to chest, but it's whatever position they want to be in. They'll get into the position that feels the most comfortable to them. And then that's kind of what it is. So sometimes they lean forward too, to get that pancreas kind of away from the back. And so by leaning forward, it kind of keeps that pain off of them. Next is calcium is low. We talked about epigastric pain, nausea, vomit, Turner sign, which is Turner trunk. Oh, that's a penguin. All right, I'm definitely tired today. All right, what else do we see here? So then we have, we're going to move into chronic pancreatitis. So that was acute, right? So acute's an acute thing right now. This is chronic now. Somebody who has an ongoing issue with pancreatitis. And this is some things that we do. So first things on chronic, things that you do see is steatocituria, which is basically fatty stools. And the reason is these fatty stools actually, because the body can't digest it, and when it comes out, the fat comes out with it. So the stools stink, and they're really fatty. What else do you have? You have weight loss because they're malnourished, so they're not getting their vitamins, they're not digesting their food. They have on-and-go abdominal pain, they have severe bloating going on, and they get this ADEC vitamin deficiency, fat soluble. That's what you get there. They're going to have acute episodes of on and off pancreatitis. All right, so some other things you have here is some meds that you give. You give Mick, sorry. Used to be Mike. Mick, morphine, imipenem, cimetidine, and ketorolac. Call on Mick to treat pancreatitis, and morphine for pain, but we also dilaudid imipenem antibiotic. That's if they become septic. Cimetidine, histamine blockers, and antagonists, and ketorolac, which is an NSAID, super duper Motrin. A lot of times we'll do that in the emergency department for your drug seekers. They'll be like, "Oh, I got a lot of pain." You're like, "All right, doctor ordered some ketorolac for you." And they usually don't know what it means. So when you give it to them, you come back, do a pain assessment back on them, and they're like, "I didn't feel anything from that." I'm like, "Well, it's Motrin, so it's probably not what you're looking for." All right, so some other things that you'll see. Okay, so that's some of the meds on acute that we do give. Ongoing, we do small, frequent meals. All right, just think about what's happening. The pancreas is having difficulty digesting and all that stuff. So you don't want to have large meals. You want to have small. All right, so FLAB, F-L-A-B, CHAP. Okay, so fats low, and then carbs high. Okay, that's what you want for the diet. You're going to avoid alcohol, and then you're going to give them bland with proteins. So a good thing for them is chicken, potatoes, but nothing fried, nothing with fat. All right, there's another thing that you have here is called pancreatase, which is a pancreatic enzyme. So just think about what the pancreas was doing. Now this is doing it for you. Now some specific things about this medication is it's tested on, and the reason it's tested on, it's not that what are you going to get. They just tell you what it is, pancrealipase. And you need to know these specifics about it. You take it with food. You take it with a full glass of water. You wipe your lips, rinse your mouth, because it's an enzyme, right? So it could cause problems. And then you take after antacids and cimetidine. And it's supposed to be taken with every single meal. So that's pancreatitis in a nutshell. So we're going to move to the final thing here. So a patient with pancreatitis might be, they could walk in. They're not going to be sitting in the doctor's office. They'll come in by the ambulance. They could be on the floor. It doesn't really matter what sex you are. Choose your parents wisely. And the age is really irrelevant. Symptoms 3 is epigastric pain. That's one of the main ones that you tend to see. Epigastric pain on the left shoulder. And the patient is vomiting, usually. Nausea. Precipitating. They could have chronic pancreatitis. They could have an ERCP. So that tends to be what happens. Main condition is pancreatitis. Main complication is peritonitis and also sepsis, ARDS. The acute 3 that I would call the doctor for is Cullen's sign, chubby belly, ecchymosis, a Turner flank, Turner sign, which is bluish around the trunk, which is also bleeding. Other nursing Q3, labs, amylase, lipase, elevated. All right, so they'll be on a monitor. Blood pressure will be monitored for low. The enzymes will be amylase and lipase. They'll be looking for the liver enzymes because of multi-organ failure, MODS, which could be related from sepsis. What else? Calcium is going to be low. Phosphorus will be low. White count will be slightly elevated. They could be bleeding. Clotting factors could actually result from the liver being affected. Sodium and potassium, B1, creatinine, and glucose. Positioning, they're going to be in a position they want to. The ERCP, they're going to look at that. They might look at an ultrasound, CAT scan without contrast. IV fluids is key, and the meds are MIC. Clotting factors can also be affected here. Temperature is going to be high. That's a risk, and that might be a risk from pancreatitis inflammation actually becoming 100.3 is usually the indicator that there's a problem. Pulse will be high, respirations be high, blood pressure will be low, mean arterial pressure low, risk of pre-renal, oxygen should be okay, fluid status low, pulses will be regular, unless they're bleeding. They might be cardiac enzymes are lipidemias, and then they'll be metabolic acidosis. Brain restlessness, heart racing, lungs, breathing, kidneys, renal. These patients are candidates for surgery, going down to the OR. They can be discharged. They can resolve this. Most acute can be resolved. They could be discharged, but most likely they're going to end up into the ICU and be monitored closely with an NG tube and NPL for at least 24 hours. And nursing 7. So what do you have? You have Turner, you have Cullen's, you have amylase lipase, you got MPL, you have NG tubes, you have ERCP, and you have peritonitis. 2, 3, 4, 5, 6, 7. Those are the main things, testing things. But there are other things on here and stuff like that. This is why the sheet's kind of good to kind of look around and see what could be affected. All right, so we've already talked about the renal thing, and that's it for pancreatitis. I'll see you next time.